Good evening, everyone. I'm here today to talk about sitagliptin in different type 2 diabetic population. You know that Januvia, the first in class DPP4 inhibitor, approved in 2006, and the most common prescribed oral anti-diabetic agent in market. The macrovascular complication, start early from 7 to 10 years before the diagnosis of type 2 diabetes. And the first macrovascular complication is heart failure and peripheral arterial disease. You know that 2 to 4-fold increase in cardiovascular disease and the leading cause of non-traumatic lower extremity amputation. The term of macrovascular complication is start with hyperglycemia, the leading cause of new cases of end-stage renal disease and leading cause of new cases of blindness. Sitagliptin here is challenging with the most toughest diabetic patient, elderly patient, patient with impairment renal function, patient with impairment hepatic function, and patient with established cardiovascular disease. Older patients, that sitagliptin used in elderly patients. Elderly patients are more likely to have renal insufficiency, as with other patients. Those adjustments may be required in the presence of significant renal insufficiency. In clinical study, the safety and effectiveness of Januvia in elderly more than 65 years comparable to those in younger patients less than 65 years. In the term of safety between older and younger inpatient running in sitagliptin, hypoglycemia, no significant difference between the two groups. But in the term of efficacy, you know that sitagliptin here, dosage adjustments, because there is dose adjustment based upon the renal function, assessment of a renal function is recommended prior to initiation of Januvia and periodically thereafter. The sitagliptin dosing, normal renal function, 100 mg once daily. In mild renal, creatinine clearance less than 45, 100 mg. So in mild and normal, we are using a normal dose of sitagliptin 100 mg. In moderate renal insufficiency, creatinine clearance between 30 and 45, we're using 50 mg QD per day. In severe renal insufficiency and end-stage renal disease, we are just adjusting the dose in 25 mg QD. Next. Sitagliptin efficacy is similar regardless of renal function. So if we are using sitagliptin in patients with mild renal impairment, and in moderate renal, and in end-stage severe and end-stage renal disease, we will see that the A1C reduction is equally in the three arms with the three different doses, 100 mg in mild and 50 mg in moderate and 25 mg in severe, all of them reducing the A1C to the same level, about 7.7% after 1 year. Sitagliptin versus glipizide. So why glipizide? Because glipizide can be used in all stages of a renal function without adjusting dose. So we are comparing the CETA with glyptide in patient with type 2 diabetic patients in moderate to severe renal impairment. You know, after 1 year, there is no significant difference in A1C reduction between the two groups. A1C here reduction in sitagliptin 7.8 and the glipizide 7.8. So the efficacy not affected by different in dose and different renal function. But there is significant difference in the term of safety. Hypoglycemia in favor here of sitagliptin in all types of hypoglycemia. Symptomatic hypoglycemia, severe hypoglycemia, hypoglycemia required non-medical assessment and required medical assessment. And you will see here in TECUS, in arm of the kidney function, there is no significant impact on a cardiovascular or CKD outcome, irrespective of a baseline estimated GFR after 4 years trials. So it means that sitagliptin not cannot affect or not safe on kidney function and cannot injure the renal function. Next, we see here a microalbuminuria after 4 years between sitagliptin and the comparator, and the renal failure non-inferior to comparator. So it is safe on renal and kidney. Now this is a profile of anti-hyperglycemic medications in renal function. Now in red column here, metformin is contraindication in GFR less than 30. Sulfonylurea and insulin have risk of hypoglycemia. GLP-1 here, xenogenic group, exenatide and the lexenatide groups cannot be give contraindication in creatinine clearance less than 30. While the liraglutide has a benefit effects in leader study on renal outcomes. SGLT2 inhibitor, contraindication in GFR less than 45. Contraindication. But the study designed for canagliflozin and empagliflozin and dapagliflozin proven beneficial effects on renal function. DPP-4 inhibitor, dose adjustment in renal function, except linagliptin. Why? Because you know there is all of them almost excreted through renal. Sitagliptin about 87% excreted through renal, vildagliptin 85, oligliptin 65. So those adjustments must be in renal, must be necessary in renal function. What about liver disease? What about mild and moderate liver impairment? Sitagliptin, no dose adjustment is necessary for patients with mild to moderate hepatic impairment. Now, what about severe impairment renal function? Januvia has not been studied in patients with severe hepatic impairment. Next, what is the impact of sitagliptin on liver enzymes? Not increase in sitagliptin pooled safety analysis. See here that ALT and AST not increased in both patients with running in sitagliptin versus placebo or comparator. What about cardiovascular established patient with established cardiovascular disease? Now we have in sitagliptin. Sitagliptin in a design safety study to proven safety and non-inferior to comparators in a term of triaiomesis and hospitalization for heart failure. And you know, here this is all the safety trials for all the DPP-4 inhibitors. You know that in 2008, after the disaster of rosiglitazone, FDA put an obligatory regulation for all anti-diabetic agents, called it guidance of industry, and all the new anti-diabetic agent must have study for at least from 4 to 5 years to proven safety in a cardiovascular diabetic patient. So allogliptin study called Examine, Lina, Carmelina, Saxa, Savor, sitagliptin, Chicos, Vilda, no studies. What about the Chicos cardiovascular safety trials of sitagliptin here? The primary composite endpoints show that Chicos cardiovascular safety achieved its primary cardiovascular endpoint. In both triaiomesis, non-inferiority to comparator in non-fatal MI, non-fatal stroke, and no increase in cardiovascular risk. What about secondary composite and hospitalization for heart failure? Shows shows that sitagliptin is non-inferior to comparator in the term of hospitalization for heart failure. And this is the secondary analysis of TICOS shows that the first heart failure here, hospitalization for heart failure, this is done. This is TICOS study is done for 4 years and selected patient, type 2 diabetic patient with established cardiovascular disease. The primary composite here, non-inferior to comparator, cardiovascular death, non-inferior to comparator. Secondary composite, hospitalization for heart failure or cardiovascular death, non-inferior to comparator, and even all-cause mortality, non-inferior to comparator. But the cardiovascular safety of allogliptin Examine shows that trend for increased hospitalization for heart failure with allogliptin compared with comparator. In Savor, saxagliptin, hospitalization for heart failure was significantly increased with saxagliptin compared with placebo. Conclusion here, sitagliptin safe in mild and moderate severe renal impairment in all chronic kidney disease, but we must adjusting the dose based on the renal function. Sitagliptin safe in mild and moderate hepatic insufficiency. Severe cases, no clinical experience. But cardiac failure, TICOS demonstrated non-inferiority of sitagliptin in the term hospitalization, heart failure versus comparator. Now, sitagliptin use, and special population. We called it sitagliptin use. Our challenging with toughest patient shows mild and moderate hepatic impairments, we can give it. Severe, no clinical experience. In mild and moderate renal impairment, 100 mg and 50 mg. In severe renal and end-stage renal disease, 25 mg, and we can use it safely in elderly patients more than 65. That is the end of my presentation. I hope you enjoyed. Thank you for your attention.